California Healthcare Foundation webinar of the Opioid Safety Coalition's network, Evolving Your Goals, Coalition Strategy for Impact. Today's webinar is brought to you by the Opioid Safety Coalition Network Communications Support Team, IE Communications. Lori Cappy is President. I'm Elizabeth Galicia, Vice President. A bit of housekeeping as we get started on the webinar. The session will be recorded. It will be posted in a week at chcf.org/OSCN. You as attendees are muted during the duration of the presentation, but we encourage you to ask questions or comment by using the chat box. And if you have logistical questions about the webinar itself, use chat to the host. If you have questions for the speakers, use chat to all. And we do have a short evaluation. Please take a moment at the end of the webinar to offer us feedback. Today, we're going to work with coalitions to review some of the trends on coalition progress a year into coalition work, highlight some of your successes, and outline tools for evolving goals and strategies, and also offer some tips for enhancing the strength of your coalition. And a note to some of attendees at today's webinar, we have several people participating who aren't directly involved in coalition work on the ground here in California. We welcome your participation and involvement and hope that some of the strategies and tools give you some insights into the work going on and can help you with your opioid safety work. So before we dive into the goals and strategies, we wanted to step back a little bit and look at coalition work that's been going on and has been in the works for years now, and show how the strategies that can have real impact. There are two coalitions, RX Safe Marin and Prescribe Safe Monterey, who have been doing this work for 3-5 years already. They're mentor coalitions for many of you. And they're really seeing gains in terms of seeing overdose deaths going down, prescription rates. So they're applying the strategies that you're applying, and over time, they're seeing results. The number of opioid prescriptions in Marin County has dropped with every year that the coalition has been in operation and is now below the state average. And opioid overdose deaths have also fallen in the county. And Prescribe Safe Monterey, there was an article yesterday in the Monterey County Weekly highlighting the progress that the county coalition has seen in prescribing rates, and also the overdose rate in Monterey County has decreased by 28%, in the first 2 years of the coalition work. So that should give you perspective. A lot of you have been doing this work for maybe a year or less than a year, and it really can show you what can happen over time. So what are the overarching goals of your opioid safety work? So the coalition network and the Opioid Safety Initiative at California Healthcare Foundation has the goal of reducing overdose deaths by at least 10% by 2020, and using the following strategies: instituting safer prescribing practices, increasing access to MAT, to medication-assisted treatment, and increasing access to Naloxone. Now, these strategies, you'll notice that we don't have on here some of the work you're already involved in that really looks at safe disposal, safe storage, some of the what we see as more the demand side of your strategies. And what these three strategies look at is supply. So how are we looking at changing 2 decades worth of provider education and practice in prescribing opioids, making sure that communities have access to overdose antidote, and that those who need it have access to treatment. As you start to evolve and are seeing gains in some of these strategies, you do want to be looking at the demand side. So how do you influence consumers? What kind of patient education can you do? Where does as they're starting to see the availability of opioids change, how do you influence behavior? And so we'll weave that into some of our discussion on evolving goals, looking at the demand side. So we're going to take a look at some of the progress and gains that coalitions have made over the year. And to do this, we're going to show you some of the work that's been done and some review of some of your goals and some of the trends in the goals. And I want to give credit to your coaches on the ground who've been working with coalitions on a regular basis. Christine Cristobal, who's also with us on the webinar here, has been working closely with a lot of you, as well as Danielle Carter from Partnership Health Plan, working with several coalitions as you work through many of your goals and milestones. So in this work, Christine, along with coalitions, has been tracking milestones through some charts to show progress. And these give you a sense of how coalitions in general are doing, whether they've started up work, have made progress, or achieved milestones in our key strategy areas. So just a big picture look at what the milestones and the strategies in our the work looked like a year ago. So this was when many of you were just starting your work, your coalition work. And as you can see, it's really, it was starting from the ground up and really building your coalition, doing and planning and figuring out what your priorities and strategies were going to be. So this gives you a real sense that that over the course of the year, a lot of progress has been made. And as I move through, I'm now going to move through a couple of we're going to go through these in turn. We're going to go through each of the Safe Prescribing, MAT, and Naloxone goals to show you specifically where we're seeing trends in progress. It may be that as you see your coalition and the work going on in a certain box is red or yellow or green, and you think it maybe now is a different color. This isn't an exact science, and we're really looking to, and you'll work with you'll work with Christine, you'll work with Danielle to make sure that they're updated. We're really looking as a coalition, where are we seeing some of the trends in progress and where some lessons can be learned. So we'll start with Safe Prescribing, and this is as of this fall. And as you can see, many red boxes have turned yellow and even green. So what are we looking at here specifically when it comes to Safe Prescribing? We're looking at adoption of community-wide guidelines in a range of settings. So in the emergency department, in primary care, in urgent care, and in other settings. And then we have the bottom line is a system to monitor if guidelines are implemented. So once you have guidelines, how do you track implementation? So really, if you look, the ED guidelines, more than half of coalitions now have guidelines in all of their emergency departments, which is really quite significant. And kudos to coalitions for that work. Primary care, oftentimes coalitions have a lot more primary care offices where for adoption of guidelines, and the population is just bigger and the N is much bigger. So the work is ongoing there, and more than half, two-thirds of coalitions are making headway in that area. Urgent care, it's about half, and guidelines in other settings, the work is beginning. And I'll take a pause for a minute. We're going to talk through how goals will be evolving. I do want, if you end up having questions either about the chart and you want to ask them in the chat, we'll address those as well. So how can you think about evolving your Safe Prescribing goals as you have your coalition, as you're continue to build your coalition and your strategies? So as we discussed, it's somewhat moving when you have adoption, say at the ED level, which we've seen half of our coalitions have adoption of ED guidelines. What then? How do you track implementation? How do you monitor whether those guidelines are being followed? So that's a challenge we've heard coalitions are addressing, those that do have guidelines in EDs, and it's certainly a next step once you've reached the goal of having guidelines in your emergency departments. Also targeting new practice areas. So as you have a proof of concept and you say, okay, we've worked with stakeholders in emergency departments and we have the guidelines drafted, they can be revised and they can be implemented in other settings. What are other areas, dental, the research shows that dental offices and opioid use, that's a key target area to reduce prescriptions there and to make both providers and consumers aware of the dangers of opioids when it comes to dental procedures. So that's one setting. And now these last two bullets speak to the demand side, as we discussed. As you're making strides within your community where the access to opioids is changed in the ED and other settings, you have consumers who will be asking for and expecting a certain level of treatment. You want both alternative pain management to be covered, to have options, those options to be available, and to have tools to educate consumers about those other pain, how to manage their pain, and influencing patient behavior. One of the doctors in the coalition puts it to bend the demand curve. So it's really looking at changing an approach to pain management and helping demand to meet a shift in supply. So we're going to take a look at some success strategies, and if you recall, when we were looking at the grid a minute ago in Safe Prescribing, SafeMedLA in Los Angeles has greens and yellows all the way down, and that's because they've made terrific strides in implementing safe prescribing practices across the county. Joel Hyatt from Kaiser Southern California has been leading the charge there, along with Gary Tsai and others, in a really strong coalition to realize initially all 76 emergency departments in the county have safe prescribing guidelines. I believe it's 80 urgent cares, about 1 in 3 urgent care clinics countywide have adopted guidelines, and they work with LA Dental Society to adopt guidelines as of January 1st. And Kaiser Southern California is engaged in the work, and prescribing is down 30% since 2010. And in 2017, their next step is to launch their primary care effort. Knowing what a large project that is for Los Angeles County, they wanted to prioritize and show successes in these other areas, in these other settings. So what were some of the key strategies for SafeMedLA? How did they achieve some of these successes that might be relevant to your work, where you can use some materials or some of the tools that they used in realizing some of these gains? So they did outreach to each emergency department individually, 76 EDs, because there isn't a joint organizing body whereby all of the EDs meet regularly, or they have very different leadership and bureaucracy as in many of your counties. So what SafeMedLA did is co-wrote a letter with the County Department of Public Health and organized the emergency departments that way. They also had a health systems roundtable where they gathered health plans, provider groups, for a roundtable in October, where everyone wrote up an action plan and committed to that plan and this gets at the implementation piece. So what are you going to do to ensure implementation of these guidelines? And they're doing a follow-up survey going out, I believe, in the next few weeks, and they're also doing another roundtable meeting in March, bringing together the same stakeholders saying, where are we now, and looking at some of those metrics. Last August, SafeMedLA hosted a pharmacist pain management conference. More than 200 pharmacists came together, and they covered safe prescribing practices. They covered naloxone access and medication-assisted treatment. And that was a way to inform and educate the pharmacist community. And that's something that can happen on a small scale. It can happen, it can be a brown bag lunch, or it can be an all-day conference. These are the sorts of things, and they have materials that they distributed, and I believe a toolkit. So those are also materials that could be available to other coalitions. How they engage the dental community. So SafeMedLA worked with Los Angeles Dental Society, and they had a champion who's part of SafeMedLA, who was able to help to make inroads with the society and get the guidelines drafted and As of January 1st, all the dentists in LA County will be adopting these guidelines, and there's a copy of the letter that went out from the Dental Society and SafeMedLA. And you can see the guidelines are clear. It says 3 days or less will often be sufficient. More than 7 days will rarely be needed. So this they'll launch January 1st and have guidelines in there in the dental community. And to celebrate these wins, and this is one of the strategies that really can help with their next phase of engaging primary care providers, on January 1st, they're going out with a public announcement announcing the county as an opioid safe zone. So they'll be able to point to the guidelines in emergency departments, in urgent cares, in the dental community, and say, this is what we're working toward, and that really inspires others to get involved and to adopt guidelines as well. So, and LA is a pretty big county, and they have some strategies that really do address their large systems, but some of our smaller counties have some other tools and strategies that have worked for them when it comes to education and adoption of safe prescribing practices. So in Placer, Nevada, they've hand-delivered their safe prescribing guidelines to each provider, and you can do that in some of these smaller counties. And with the office visit, they drop off pain flyers. And these flyers, the Got Pain, There Is No Magic Pill, offers up alternatives to opioids, and is meant to be that in-office pace and education piece that can complement changing prescribing patterns. In Sonoma, this summer, the Sonoma County Medical Association magazine published a 10-page in-depth package on strategies for reducing opioid use. It was a mix of both strategies from experts. Gary Pace, Marshall Kubota from Partnership Health had a piece, along with the data and evidence of why this matters and where inroads have been made elsewhere. So that's really speaking to the audience. You know, that's if you're talking to the medical association, you're really talking to the doctors who are the prescribers in that community. And in Santa Cruz, they've launched an opioid failure series that really explores the changing landscape of pain management. And this is a continuing education academic detailing effort where really a roadshow where they're going into different settings and talking about opioid failure, which is the persistence of chronic pain despite opioid use, and then strategies to address that. Here's a screenshot from a presentation that they did in a palliative care setting. So there's been a lot of work in Santa Cruz to really reach out in different settings and discuss safe prescribing. Yeah, so there it's opioid failure in palliative care. So that gives you a sense of what some of the other coalitions, and this is by no means comprehensive. Each coalition is working on a strategy that's customized to their communities, to their providers in their communities, and have different tools. And we have a folder that we'll show you where it is at the end of the presentation, where we're tracking and keeping all of the tools and strategies that work for people, and is on a shared Google Drive, so you can see what other coalitions are using. And with that, I'm going to turn it over to my colleague, Lori Cappy, to walk us through our other strategies.
Hi, thank you, Liz. So I'll have Liz, as needed, help me fill in details because she's been much more integrally involved with some of the coalitions. My view on this is based on my experience in terms of how do you generate coalition work that can influence policy as well as practice. So I wanted to start out with the very important policy option and strategy that's being used to reduce opioid deaths, which is the use of medication-assisted treatment. I know everybody's pretty familiar with medication-assisted treatment, but just to recap quickly a definition, it's what uses a combination of both the proven medications as well as the social supports and counseling to treat people with opioid dependency or addiction. So despite the efficacy of this approach, we know that somewhere between 10 and 20% of people who would need or be eligible or for this type of treatment are able to access it. So there's quite a lot of work for us to do to get from that 10% to the 100% uptake that we would like to see with this policy and practice. So this strategy, at the beginning, we saw the first few slides where there was very little progress that had been made on this policy option. And it's very heartening to see that in this last year, in terms of actually developing a plan, which is one of the important milestones, you can't reach the objective if you don't have a roadmap or a plan of how to get there. And as you can see, there's the green boxes of LA, Santa Clara, and Shasta, so they've got a plan in place. And there's progress being made towards plans in the other counties. And not to say that Mendocino and Napa and Siskiyou may not be making any progress. And again, take that up with Christine later if you have. The other important milestone, of course, is you've got the plan, and how are you measuring actual access to medication-assisted treatment? And less progress being made on that score, but that just shows that we've got challenges ahead in this next year. So taking the very basic two milestones, which is having a plan and then having the access, we've been doing some brainstorming here, thinking through how do you evolve those goals? What are interim milestones that are going to get you from that 10% currently accessing to the 100%? Well, one is ensuring that you can have medication-assisted treatment in some of the very specific settings where our target population, i.e. those with addiction to opioids, come in the door. So we'd like to have this be that there's no wrong door. So whether you're walking in the door of your primary care physician, whether you're walking in the door of a clinic, whether you're walking in the door of maybe not of your choice, but in a jail, that you would be offered what we know to be both proven and effective response to that addiction. Another access point, interim goal, is to work towards ensuring that existing health plans offer the option of medication-assisted treatment. A third one here, which has a clever title, but hopefully everybody gets it, but we do have people who are getting or getting the certification to have X licensing, which is allowing them to be prescribers of I never pronounce this one correctly, but help me. Buprenorphine. But whether they're actually moving forward is going from having the license to actually prescribing. So that's another important milestone to be targeting, is how to get that subset of clinicians in your county that have X licensing to actually be prescribing. Another milestone towards this ultimate goal is to work with the clinics, particularly those that have the most access to people with addiction, on implementation, because the implementation, as we also know, is more than just the prescription. It's also providing the social supports and the counseling so that we don't have that we're able to deal with the anticipated relapse, which we know is part of that trajectory. And finally, and not finally, because I'm sure there's plenty more interim milestones, these are just the ones that Liz and I have been brainstorming, but is, you know, perhaps one of the biggest ones, which is destigmatizing addiction treatment. I also just want to point out on the right a really cool little infographic that is on the CHCF website, and would be good for you to, if you haven't looked at this, to take a look at it and take a look at the report that goes along with it. Liz just reminded me that it's not her and I that are sitting in some ivory tower coming up with these interim milestones, but that clearly many of these come from the on-the-ground work that you're all doing, and that we've heard from you as interim milestones, and that may be part of your plans as well. Go to the next slide. So now we want to share kind of a best practice. So the reason that we've been highlighting different aspects of different working coalitions is we really want to encourage that cross-county learning or the cross-coalition learning, because, you know, you've got getting experimenting and working out different strategies going on in all the different counties. And I have often found that, you know, the most valuable lessons come out of work that your peers have done. And to any extent that you can adapt and adopt it to your local coalitions, we really truly want to encourage this. You know, there's no patents on any of this work. So one, and I don't know if it's the only one in of all the coalitions, but I do want to do a particular shout out to the induction clinic in the ED at Highland Hospital. For those of you who are not familiar, Highland Hospital is the public hospital, primary public hospital in Alameda County. And Dr. Herring has been doing terrific work there in offering medication-assisted treatment in the emergency department. So rather than just being able to share safe prescribing guidelines and do a referral, there isn't going to be that wait time. And right from the beginning, you know, from the work first walking in the door, you can be able to access that. So I want to share with you, if you wouldn't mind indulging us in hearing Dr. Herring describe this himself, and think of this as, you know, if you could share this video with some of your emergency department heads in your county or community, or perhaps you can get Dr. Herring to get them on the phone. So here we are, we're going to share a little bit of a video with Dr. Herring.
The details of buprenorphine from a pharmacological standpoint can help you understand that this is not methadone. This is not just another opioid. This is a whole other opportunity for treating addiction.
Okay, so there's much more to Dr. Herring's video, but we just wanted to share that quick clip. And we do have plans of putting these videos that we have from interviews that were done at the 2 convenings with various champions and innovators on different aspects of the Opioid Safety Coalition Network strategies and goals. Okay, we're going to go to the next slide now. In addition to having a champion like Dr. Herring in the emergency department, Alameda County has gone to another door. So in kind of the metaphor here of there being no wrong door, we're looking at having buprenorphine treatment at all the federally qualified health centers. And that has been done in a pretty systematic way by working with, at the county level, with the Behavioral Health Director Department to institute changes at the actual contract level. So instituting that at, and there's, I'm sure Alameda County would be happy to share the letter and the agreement that they worked out, but basically they really got into the weeds. So they added language to every contract that each addiction clinic must have 2 X-licensed doctors by the end of 2016, and that it's not just that they got these doctors, but they're looking at going from, like we said, the X to the RX, and ensuring that there's at least one patient on buprenorphine by March 31st and 5 by June 30th. So this is what I like particularly about this, is that it's going from aspiration to implementation. So now, quite a different challenge when you're talking about MAT in a large urban county like Alameda County versus some of the rural counties. And in doing interviews and working with some of the smaller counties, which, as many of you know, also have a disproportionate amount of addiction as well, if you look at the data. So, there's an urgency to this. These are, by being a smaller county, these are your friends and your neighbors. These may be your child's teacher. This is something where there's can be very much a face on those with opioid addiction. And so the approach is kind of similar. It's saying, we may not be prepared to make the large-scale systematic changes right away, but we can start small. We can start in Northern Sierra with one patient at a time. And that's the approach that's being used, for example, in Plymouth, Modoc, Lassen, Sierra. Let's just find that one providing doctor with the X license who will agree to go from X to RX and save at least one life or change the trajectory of at least one life at a time here. Similarly with Shasta, this is not that small. This is saying we have as a goal to get a training in the next month for at least 50 to 60 docs. And towards that goal, they've identified 10 docs and are, instead of trying to get everybody into one place, they're making the effort to just do the one-on-one meeting so that they can answer the questions, be able to put this approach into context, and have an effective way to turn those X licensees into RXers. In Tuolumne, they have one medical clinic, I think in the county, I'm not sure, but hopefully if somebody's on Tuolumne, they can correct me. And they're dedicating at that clinic at least 2 half-days every week to see patients and to follow up with medication-assisted treatment. Okay, so I'm going to take a brief pause, and hopefully some of you have been taking notes, or if you have questions, please be sure to post them for us. So now we're going to move to the third strategy towards our overall goal of reducing opioid deaths. And as everybody on this phone, I'm sure, is aware, naloxone is an opioid overdose reversal medication, and it's definitely been proven to save lives. However, there's a lot of challenges around naloxone. And the Opioid Safety Coalitions have been working to deploy naloxone through a variety of settings. So the first milestone was to actually have a plan. And to get a plan in place, identify what those settings might be, figure out what the barriers towards making naloxone accessible, whether it was stigma or whether it was cost, what was the resistance point. So pleased to see the progress that has been made on this. We're having, one might hope, a fairly effective plan in place has merited you a green. Quite a few of you have greens. There's a smattering of yellows. And again, if you're red, take it up with Christine. On the going from having a plan to actually being able to have some sense that there is this access for that very vulnerable population that is at risk of death from an opioid overdose, clearly a very important milestone. We're seeing quite a few greens that have been able to demonstrate, at least in terms of our trends chart, that they have access to naloxone in place. And then this third one, which I think is critically important, which is having naloxone is a one-time reversal. So what's going to prevent that person who's had that one-time reversal through naloxone from relapsing and going back to their chronic addiction. So having in place a way to have tapering guidelines for those that are chronically opioid dependent. And again, this is where the three strategies are clearly interrelated. So, you know, it's not just that you want the guidelines, but you want maybe some of those guidelines to be able to provide that person with access to medication-assisted treatment. So now, again, listening to the coalitions and scanning the coalitions in terms of how you're coming up with related or other milestones or evolving your goals to have further impact, because obviously this is all about having an impact on reducing opioid deaths. Working with pharmacists has come up as a very important interim milestone. So having pharmacists willing and able and having the training as well as the certification to furnish those naloxone kits. The other one that we wanted to point out is, again, with the notion that there is no wrong door. So if you have somebody in the door who you know is opioid dependent and has just gotten a prescription for additional opioids, in Monterey, they are now, in a sensitive way, co-prescribing naloxone. So letting people know that you are taking on a risk with a very risky, with opioids that have this very serious risk, and here let's give you a prescription as well for naloxone. So that's been happening now in Monterey. A third, and as you've noticed, we probably use the word destigmatizing in almost every discussion of every strategy, but getting both the first responders and others in the community in particular to have an appreciation of the role of naloxone and destigmatizing it. And the last one is, it's not the last one, there's probably other milestones that we could do to on this particular strategy, but is addressing the high cost of sustaining that naloxone access. We've seen, I was asking Liz yesterday, and we were working out, you know, what is the cost of some of this naloxone access, and it kind of ranges pretty dramatically in terms of the cost. So we want to, and you know, that's perhaps, you know, the subject of an entire other webinar, but is how to address the cost of some of these access to naloxone. And so now we want to share with you the particular good work that's being done in Santa Clara, and as an example. So one of the things Santa Clara has been able to do is get trainings and kits out to, I think, pretty much all their addiction clinics, as well as their residential clinics, and making needle exchange available as well. An unusual, maybe not that unusual, but I thought it was very creative, is to work with the local universities and train the RAs, which, what did we decide they are called? Resident assistants. And back when I was in college, those were the folks who were about making sure you didn't drink too much beer on the weekend. But we now have, you know, very life-threatening opioid use going on some of these campuses. And the importance of not turning a blind eye to that and recognizing accountability and responsibility for that by actually training those RAs in how to respond and making them, in fact, our first responders in those campus settings, as well as the campus police that may be called, you know, whatever the equivalent of a 911 call is internal to a campus. The other thing that they've done is very determinedly gone to law enforcement in each of the cities in Santa Clara. So there's 15 cities in Santa Clara, and 4 of them have now agreed to supply naloxone kits in the police cars. So the first responders have those available. So here's to give you some of the tools. So we're giving you, in each case here, some tips and tools. And again, I want to encourage you to adopt and adapt. And there's no patent on any of these materials or copyright. So, you know, you're perfectly welcome to change the phone number and, you know, change the county name and, you know, adapt them and use them appropriately in your county. But the ways in which they've achieved some of these milestones is by sending out letters to the clinics and following up on those letters, joining meetings, existing meetings, which I often encourage people who are doing coalition work. I mean, it's a lot of work in setting up your own meeting, so it's a good practice to find out and piggyback on meetings of some of your target audiences they may already be having. They have an in-house trainer now on naloxone. They've partnered, I don't know if they purchased them or not, I have to ask Liz, but if they either purchased the newspaper ads or if they went to the newspapers directly and asked them to do it as a community benefit.
I think a combination.
Yeah. Because a lot of times local newspapers are willing to do this kind of thing pro bono or low bono in order to show their commitment to community health. So that's another great idea for people like myself who still actually read newspapers. There's also, they're providing trial kits. So the coalition has invested the dollars into supplying those first kits, and then encouraging and supporting those ancillary organizations to figure out how to come up with the budget so that they can continue to supply them. And we're not going to show it to you now, but they also worked with one of their youth groups. As you can see, they have had a focus on some of the campuses, and the youth produced a video. So we're going to just show a screenshot of it. Yeah, so this is a screenshot of it. We'll just show you a little bit of it so you can get an idea of, you know, as a communications person, one of the things I really appreciate is when you do have kind of peer-to-peer communications. So if you want to speak to 20-somethings, the best thing is to have 20-somethings come up with the language and the message. So here's just a quick snippet of it.
Yeah, and this was produced by students from Stanford University with the coalition in Santa Clara, the Santa Clara County Opioid Overdose Prevention Project. We'll just show you a little bit of this.
Hello there, students, classmates, colleagues. I'm with the Santa Clara County Opiate Overdose Prevention Project, and I'm going to tell you a little about our national problem with opiates and pain medications, such as Vicodin, Oxy, and fentanyl. When we hear about drugs, we tend to automatically think of illegal, hard drugs. But one of the root causes of the U.S. opiate addiction is the widespread abuse of prescription medication. Opiate use has reached epidemic levels. It is just as severe as the world's notorious disease outbreaks, like SARS in Asia or Zika. 500,000 people have died from drug overdose in the U.S. between the years 2000 and 2014. 60% of them died from opiate overdose, according to the Center for Disease Control. In the U.S., people of all racial and ethnic backgrounds and of different social and economic.
So, and this is Liz again. We're going to stop it here. We'll have it for everybody in the slides and available for download. And just a note about this video, it's actually, as you can see, it is literally a post-it note video, which is a level of brilliance for young people to produce this and to have a narrative behind it. As you watch through, it's about 4.5 minutes, and they provide phone numbers to call, resources, a mix of the data of what's going on nationally in the county and with young people. So it really is directed at their peers. So that's an example of a strategy of really having that peer-to-peer conversation.
So now I want to turn to kind of the last strategy again, I keep harping on that we have an overall goal of reducing opioid deaths by 10%, at least 10% by 2020, and we have a variety of strategies that we've highlighted today, safer prescribing, MAT, and access to naloxone, as strategies along the way to that goal. But there's not the theory of change that is underlying the California Healthcare Foundation's overall initiative is to do this work on advancing these strategies through coalitions. And so what makes a good coalition is as good as and as representative as its membership is. Because if you're trying to influence county policy and practice on these strategies, you need good representation in your coalition to become effective messengers, influencers, and decision makers. So looking at this chart, and again, take it up with Kristen if you think you've got more representation in some of these categories than she's credited you with. But as you can see, looking down here for each of these categories, this is the kind of, people feel like you have pretty good representation from these categories of folks, whether it's medical folks, community clinics, hospitals, emergency physicians, et cetera. So this first slide is much more about on the professional side. The next slide is looking at whether or not you've got people from alcohol and other drug dependent, the clinics. Do you have folks that represent the patients and the family advocates? Those are very often the voices that can have the most influence because they're connecting to the hearts and the experience and the lived experience in particular. Law enforcement, DEA, corrections, medical examiners, education in schools, as well as policymakers, and particularly in the county level, supervisors, county supervisors. So at the bottom, in the aggregate, we've noted on an aggregate level what percentage in each of those categories. So now we want to take a quick look kind of the trend. So, looking at everybody, you got that nice arm raised with the big bicep there, saying how 100% of the coalitions have reported that they've got 100% showing that they've got public health or health plans involved. 93% have community clinic involvement, 73% law enforcement, 67% have pharmacists. Again, it's kind of inexact, but we want to just give you a sense of the trends. Coming on, but not quite where we'd like to see it, is the schools, the public officials, the other settings that we've talked about, like urgent care and dentists, and consumers and family advocates. So why does this matter? It matters because the stronger your coalition is, the better you're going to be able to make the case and make the change on some of the milestones we've been talking about. So clearly, this is not rocket science, but if you've got a couple of influential champion dentists on your coalition, they're going to be able to make the case with their peers and colleagues in the county. The other reason to strengthen your coalition is you don't want to look like a special interest group when you're going to a hospital or you're going to the Board of Supervisors, et cetera. There's a tremendous strength in being able to say we've got representation across these different stakeholders, all who see the value in this particular approach. And sometimes that's referred to as having collective impact. It's both at the local level by showing the stakeholders, and another important feature or a characteristic of thinking about this in terms of a collective impact framework is being able to go from the county level to the state level. So by having a certain number of emergency departments across the state in these various coalitions that have all adopted these safer prescribing guidelines, sometimes what happens is you get to a tipping point and whether or not there's a coalition in their county or not, they're going to start adopting it. And that can happen either because of state legislation, or it can happen because at the association level, maybe all of the emergency departments have meetings or work within their own coalitions, and they hear about this. So that's the other reason you want to think about how to strengthen your coalition. And finally, as I alluded to before, on an issue like this where we've pointed to consistently the importance of destigmatizing, there's nothing more powerful than somebody with lived experience that can speak to the hearts and then back it up with the data. We're not saying that it's all done by hearts and anecdote, but back it up with the data to change those hearts and start destigmatizing opioid addiction, so that we across the board have the Safer Prescribing Guidelines instituted, so that we have MAT as well as Naloxone. So one of the things I really want to encourage everybody is to think through your outreach to get those community voices to the table. So look at your materials and make sure your materials are as carefully crafted as possible, so that in your materials you have offered that destigmatizing language so that they will step forward.
And Lori, we actually had a question come through on a related topic, wondering what have we learned from our work on other issues and campaigns regarding destigmatization, and what has worked?
So I'm going to date myself a little bit, because one of the organizations that I worked for about 10 years was the National Abortion Rights Action League. And as I can't believe we may be going back to the need to preserve Roe v. Wade, but one of the things that very much helped with those campaigns is we had a campaign called Behind Every Choice is a Story, and we encouraged people who would walk into clinics to fill out a story card. So tell what was their particular experience with having to make that kind of rough, difficult, painful choice to maybe decide to terminate a pregnancy. And the more we had people willing to share their story, and we had materials and posters up that said, you know, behind every choice is a story, and provided the information and the data. We also actually got, through those campaigns over the years, a fair amount of high-profile folks, celebrities, et cetera, to also be willing to share the fact that they had had an abortion. So if you think of those two approaches, you know, one is giving a safe place for people to share their story. Put it on a postcard, have it in your clinics, you know, then ask them if they would then be willing to share their story more broadly or publicly. But giving them the opportunity to fill out a postcard was really quite powerful. And again, you know, unfortunately, we live in a fairly celebrity-driven culture, but the more we have folks who can say, I turned my life around, that gives people comfort and courage to come forward. So here, I'm just moving to the next slide. Here's just quickly a couple of examples. So Humboldt County reached out to their Board of Supervisors and asked them to, provided them with a proclamation. And this has, you know, provides a good imprimatur and a way of bringing in other stakeholders. If you have at the top level, which is your Board of Supervisors, putting out this proclamation. I don't know if it's true if it has trickled down in Humboldt, but my sense would be it would then help with other public officials, whether it's Health and Human Services, whether it's child welfare, law enforcement, et cetera. But if the Board of Supes have signed on, hey, why don't you guys sign on also to this, to taking this approach? And then we also have a flyer here from annual meeting that was just held a few days ago, and I know Liz did go to it, and she said it was just amazing, the number of people that attended, representing the full range of the coalition involvement. I think you said they had about 200 people at least that came to this. So this is an example of how do you engage the community, and had a very robust agenda that shared information and shared strategies, and kept the keeping the community energized. So they have many green cells in their progress chart.
And that's why they're a mentor
yeah.
coalition.
Right. Okay, so I'm going to turn this over now to Liz, who's going to talk to you about some of the next steps following this webinar.
Yeah, so I'll talk next steps, and thanks so much, Lori. We do have another question that's come in that I'll address first. Have you seen progression and evolution of communications-related goals or activities from internal to external coalition communications or materials or priorities coming from the coalition? And I would say working closely with you all at the coalition level, we started out with a lot of, as you build your coalition and try to organize yourselves into action teams and figure out your priorities, it becomes how do we organize our internal communications, whether it's emails or newsletters, and figuring out how to be the most efficient and effectively use people's time and keep people informed and also engage new stakeholders. I've really seen, and this speaks to as you start to change the supply curve, how you address that with demand, that we're seeing much more coalitions wanting patient-facing materials, PSAs that they can buy time slots or have time slots on the radio, and patient-facing stories, and where they can go to their local churches or Rotary clubs and really tell the stories and testimonials of people in the community. And having websites and data stories, so using the data dashboard from CDPH and using the data that's coming through to help tell the story of what's happening in the community for community members. I'd also say that as we're seeing some gains and some of this traction with on some of our goals, so with access to naloxone is an example of where CDPH with having funding to distribute community-wide distribution of naloxone coming up, that becomes an effort for the coalition to say, from a communications perspective, okay, if we have this opportunity to now have more naloxone kits in our needle exchange clinics, addiction clinics, in libraries, and other community settings, how do we communicate with, train, and support community members who will be administering that naloxone, and also address that stigma of people feeling like it's okay, I can go pick up a kit, and it's something to feel like that there's that they really have access and are able to use the resources that are provided at the community level. Did you have anything to add to that? I'll move on here.
No, I guess the only other thing to your question, looking at the person from the question, is one of the things that we've also seen as one of your goals is to use the media as a way to reach communities, policymakers, et cetera. And there's almost 3, 5, 10 articles every day that relates to the opioid epidemic, and some of them are starting to go from highlighting the problem to offering solutions. And we have seen that trend overall in the media and been hoping to get many of you to jump on that bandwagon, because that is a very important method to do destigmatization as well.
Yeah, so we're starting to send out coalition digests to coalitions every couple of weeks with highlights from the media that you can share with your audience on social media and otherwise. So quickly before we wrap up here, and we're available afterwards, Christine is, I am as well, and Lori for any follow-up or and support. We're going to be doing ongoing, speaking of support, adapt and adopt sessions, we're calling them. So this is beyond webinars. This is really peer sharing calls, video hangouts, where we'll have support, technical assistance, where either like in demographics or geography, coalitions will share strategies You'll be on with different mentors and advisors who can help you. Potential topics are listed here, and signups will be through mentors and coaches. So if you have any comments or questions, please don't hesitate to contact either of us. And these and other coalition tools, as I mentioned earlier, will be on the OSCN Google Drive that's in the communications folder at chcf.org on the Opioid Safety Network page. Upcoming webinars, January 11th, Coalition Core Funding, Creating a Sustainability Plan. So join us for that, 12:30 to 1, January 11th, and then a topic to be determined in February. So just a note, please offer feedback by the evaluation you'll be getting after this webinar, and thank you so much for attending.